Let's talk about the control of cardiac function. So again, let's start off as we always do by reviewing our core principles. There are four core principles that we need to know to understand anatomy and physiology. If we understand these four core principles, many of the things that we come across will make sense to us. So there are four core principles, including feedback loops, structure and function, gradients, and cell-to-cell communication. With feedback loops, there are two kinds. There's positive feedback loops, and when we think positive feedback loops, we think of increase and reinforce. And when we think of negative feedback loops, we think of set points. We know that structure and function are intimately related. There is a correlation between the two, such that if the structure changes, the function changes. Gradients exist when there's more of something in one area and less of something in the other area, and the two areas are connected. We can have concentration gradients, electrical gradients, temperature gradients, and pressure gradients. And in a multicellular organism, for a multicellular organism to function, the cells of that multicellular organism need to communicate. This is facilitated in two ways. Chemical communication, which can be for cells that are adjacent to one another or cells that are distant from one another, or electrical communication, which is only for adjacent cells. Now let's start talking about cardiac output and regulation. So cardiac output is the amount of blood that's pumped into the pulmonary and systemic circuits in 1 minute. So if you think about it, the heart rate is about 60 to 80 cardiac cycles or beats per minute. And so the amount of blood that's pumped in one heartbeat, we call that the stroke volume. The stroke volume can be calculated with two factors, the ESV and the EDV. The ESV, or the end stroke volume, is the amount of, then systolic volume is the amount of blood in a ventricle at the end of a contraction, and the EDV, the end diastolic volume, is the amount of blood in the ventricle after it is filled during a diastole. So you take the end diastolic volume and you subtract the end systolic volume, and that gives you the stroke volume. So the EDV minus the ESV equal the SV. So 120 milliliters minus 50 milliliters equal 70 milliliters. That's your stroke volume. To find the cardiac output, you multiply the resting heart rate by the resting stroke volume. So you take 72 beats per minute times 70 milliliters per beat. That should give you about 5,040 milliliters per minute, or about 5 liters per minute. So your cardiac output is about 5 liters per minute. Therefore, at rest, the entire supply of blood passes through the heart every minute, because we have about 5 liters of blood in our system. So the right ventricle pumps about 5 liters into the pulmonary circuit, and the left ventricle pumps the same amount into the systemic circuit in 1 minute. So although stroke volume averages about 70 milliliters per beat, it may range from 50 to 120 milliliters. The exact stroke volume may be difficult to measure directly, and often a measurement called the ejection fraction is used in its place. And to get the ejection fraction, you take the amount of blood that's pumped out of the ventricle and divide it by the total amount of blood in the ventricle, and that gives you the ejection fraction. And 3 factors influence stroke volume. So we have something called preload of the left heart, is determined by the volume of blood coming in from the pulmonary circuit. Then we have contractility, is determined by the heart's intrinsic pumping ability. And then we have afterload of the heart, is determined by the pressure in the systemic circuit. The left heart is determined by the pressure in the systemic circuit. So the preload refers to the length or degree of stretch of the sarcomeres in the ventricular cells before they contract. And so the degree of preload is largely determined by the EDV. the amount of blood that is drained into the ventricle by the end of the filling phase. And so two factors influence the EDV: the length of time that a ventricle spends in diastole and the amount of blood that returns to the right ventricle from the systemic circuit, known as venous return. EDV increases when ventricles spend more time in diastole because there is more time for them to fill with blood. It also rises when the left ventricle pumps blood more forcefully into the systemic circuit because additional blood returns to the right atrium more rapidly, increasing venous return. And the relationship between preload and stroke volume is explained by a mechanism we call the Frank-Starling law. According to this law, increased ventricular muscle stretch leads to more forceful contraction. Stretching causes a more optimal overlap of the actin and myosin filaments in the muscle cells, which enables a stronger contraction and a higher stroke volume. And this, of course, ensures that the volume of blood discharged from the heart is equal to the volume that enters it. And this is really important during exercise when the cardiac output needs to meet the body's needs. Now let's talk about contractility. The velocity of blood being ejected from the ventricles can be used to estimate the contractility of the heart. Increasing contractility will increase stroke volume and therefore decrease the ESV. Decreasing contractility will do the opposite, decreasing stroke volume and increasing ESV. Now that's assuming that preload and afterload remain constant. Stroke volume and heart rate generally increase together, and we have agents that affect contractility that we call inotropic agents. And these are factors that increase heart rate, such as sympathetic nervous stimulation, and also often they affect contractility, and so they increase the force of contraction. When the heart rate is too high, contractility decreases, as does preload, because the heart is beating so rapidly, it's too rapid to develop significant tension during contraction. A decrease in both stroke volume and cardiac output occurs then. So now let's talk about afterload. Afterload refers to the force that the right and left ventricles must overcome in order to eject the blood into their arteries. And this is largely determined by blood pressure in the arteries of both the pulmonary and the systemic circuits. Because as afterload increases, ventricular pressure must be greater so as to exceed the pressure in the arterial and pulmonary systemic vessels to force open the semilunar valves. An increase in afterload, therefore, generally causes a decrease in stroke volume and so a rise in the ESV of ventricles. Conversely, a decrease in afterload generally corresponds to a higher stroke volume and a lower ESV. So let's take a look at how changes in preload contractility and afterload affect stroke volume. So high preload leads to a high EDV, and this volume of blood stretches the cardiac muscle cells, and that's combined with increased contractility leads to a more forceful contraction. Since afterload is low, the forceful contraction isn't pumping against a great deal of resistance, and a forceful contraction against load resistance leads to a high stroke volume and a low ESV. So notice how preload leads to low EDV, or low preload leads to low EDV. So cardiac muscle cells are much less stressed, combined with diminished contractility, the heart contracts weakly. Since afterload is high, this weak contraction is pumping against a great deal of resistance. A weak contraction against high resistance leads to low stroke volume and more blood left in the ventricle after contraction, which is a high ESV. So long-standing increases in preload and afterload are associated with something called ventricular hypertrophy, which is the enlargement of the ventricles. So remember, cardiac muscle cells of the ventricles are fundamentally muscle cells, so they're going to need to generate more tension to continue pumping blood against a higher afterload, and they're going to respond to this type of work the same way your skeletal muscle fibers will. They're going to make more myofibrils, they're going to make more mitochondria, they're going to make more of the different organelles, and as a result, those muscles get bigger. Now remember, the heart is constrained, right? That means that it's not getting thicker going to the outside of the heart, right? Because the force goes into the lumen of the heart. So that's important to understand. So the right versus left ventricular hypertrophy is slightly different. Right ventricular hypertrophy most often results from respiratory disease or high blood pressure in the pulmonary circuit. Left ventricular hypertrophy generally results from high blood pressure in the systemic circuit. Ventricular hypertrophy can increase the effectiveness of the heart's pumping up to a certain point. The condition, however, decreases the heart lumen and therefore reduces the amount of space in which the heart can fill up, right? And that increases the risk for many heart conditions, including heart failure. The other determinant of cardiac output is heart rate, and under normal conditions, the rate at which the SA node generates action potentials determines the heart rate. So factors that influence the rate at which the SA node depolarizes, we call those chronotropic agents. Anything that increases the rate at which this node fires is called a positive chronotropic agent. And this includes sympathetic nervous system, certain hormones, elevated body temperature. A agent that has the opposite effect we call a negative chronotropic agent. This includes parasympathetic nervous system and decreased body temperature. So although heart is autorhythmic, the cardiac output needs to be regulated at all times so as to meet the body's needs. So we have a nervous system and endocrine system coming together to influence heart rate and stroke volume. And so we have two branches of the autonomic nervous system to regulate our autonomic functions. So we have the sympathetic nervous system and a parasympathetic nervous system. Now you may not be familiar with these particular names, but you are familiar, I suspect, with the way that these systems are described. So the sympathetic nervous system is in charge of your fight or flight response, right? Your fight or flight response. Whereas your parasympathetic nervous system is in charge of your rest and digest response. So we have two different needs in our bodies, right? Sometimes we need to devote everything to surviving, and sometimes we need to sit down and chill out after a meal. So the role of the sympathetic division of the autonomic nervous system includes norepinephrine, which increases cardiac output. It increases the heart rate by raising the rate at which the SA node fires up to 180 to 200 or more times per minute. And this increases the entry of calcium ions into the cardiac muscle cells, which of course cause the whole cross-bridging that we've already talked about. And a higher calcium ion concentration increases contractility of the cardiac muscle cells, which in turn raises stroke volume, and together these two effects can dramatically increase heart rate. And then we have the parasympathetic nervous system, right? Sympathetic nervous system was for fight or flight. The parasympathetic nervous system was for rest and digest. And so acetylcholine decreases the SA node action potential generation rate and actually slows the heart. And hormonal regulation of cardiac output occurs in various forms. So the adrenal medulla is activated by sympathetic nervous system, and in response it secretes the hormones epinephrine and norepinephrine into the bloodstream. Hormones have the same effects as the sympathetic nervous system neurotransmitters, but the effect is longer lasting than sympathetic stimulation. And the amount of water in the blood plays a significant role in determining the heart's preload and therefore the strength of its contraction. The amount of the water in the blood is called the blood volume. So Hormones such as aldosterone and antidiuretic hormone increase your blood volume and preload, and so they raise your cardiac output. Whereas atrial natriuretic peptide, which we've already met, decreases your blood volume and preload and therefore reduces cardiac output. The concentration of certain electrolytes in the extracellular fluid plays a large role in determining the length and magnitude of an action potential and cardiac output. And body temperature influences your cardiac output. So your SA node fires more rapidly at higher body temperatures and more slowly at lower body temperatures. And so other factors can include age and physical fitness. And heart failure is any condition that reduces the heart's ability to function effectively as a pump. Causes of heart failure include reduced contractility due to myocardial ischemia and or myocardial infarction, valvular heart diseases, and any disease of the heart itself. This is known as cardiomyopathy, and electrolyte imbalances. And heart failure generally results in decreased stroke volume, which in turn reduces cardiac output. So let's talk about the signs and symptoms of heart failure. Generally are going to depend on the type of heart failure and the side of the heart that's affected. In left ventricular failure, blood can back up within the pulmonary circuit, causing pulmonary congestion. And this backup of blood flow increases pressure in these vessels, driving fluid out of the pulmonary capillaries and into the lungs, a condition we call pulmonary edema. Both right and left ventricular failure may produce peripheral edema. So blood is going to back up into the systemic capillaries, which causes systemic congestion. And this backup forces fluid out of the capillaries and into the tissues, where it often causes visible swelling, especially in the legs and feet, where fluid collects as a result of gravity. Peripheral edema is exacerbated by the fact that the kidneys retain excess fluid during heart failure, and they do this in order to increase your preload and compensate for lower cardiac output.